Bipolar illness is a multi-organ disorder. It's a brain disorder. It affects, I always say that it metastasizes to body, but in many cases it could start in body and metastasize to brain. What does that actually mean? Well, we actually know that people who are obese as adolescents have a much higher risk of developing bipolar illness later in life. So in other words, we're seeing this metastasis of effector systems, if you will, going to their brain. We all know these patients are complicated. There's multiple dimensions to their pathology. I don't like the word comorbidity because it actually has a definition. And the definition means a concurrent problem with a discrete pathoetiology. That's how it was defined by an internist named Feinstein in 1970. In fact, we don't know the pathogenesis of bipolar illness, so we can't make claims of discrete, what we call zones of delimitation, a sunshine between the genesis of this condition and that condition. For now, we call it comorbidity because it's easier to use, but perhaps it's probably more useful to refer to these as co-occurring syndromes. Why do our patients with bipolar illness have so much overweight, obesity, diabetes? Well, we spoke to this yesterday, I think, very, very thoroughly. They have risk factors, traditional and emerging. Now, there's a whole host of conspirators that go well beyond the clinical ecosystem. They go right into the public square around economics and access to health care that are all relevant. And also, we should not forget childhood adversity. Every mental health care provider knows better than anybody else that childhood trauma increases your risk for brain illness. But sometimes we forget that it also increases your risk for medical illness, like cardiovascular disease and diabetes and obesity. What I want to, in fact, really convey strongly here is that obesity, notably metabolic obesity, which I defined yesterday, is a mood destabilizer. We have plenty of evidence now to say that people who have bipolar disorder, who are obese, are much more likely to have chronic illness, to have recurrence of illness, and also much more likely to have unfavorable outcomes of their illness. We see this both in bipolar disorder as well as in major depression. To put a few percentages out there, individuals who have bipolar disorder have a much higher rate of metabolic syndrome. The rates of metabolic syndrome in this group are hovering around 50 to 60%. Most studies would suggest slightly higher, in fact, than in schizophrenia. And this is not an observation that's unique to us in North America. We see this globally, in fact. And this is something that's not just common, it's something which we think is relevant for understanding the underlying disease state. This is a study that we did, a colleague of mine in Singapore. This was done at our NIH center in Singapore. And we hypothesized that bipolar patients who present with their first episode of mania, if they were obese, they likely have a very different illness. More specifically, we hypothesized that their brain was different. And we dug down even deeper and said the brain circuits. So what you're looking at here is a readout of what we call FA, fractional anisotropy. And all this really is a look at the efficiency of the brain circuits. So what you're seeing on the slide is that people with bipolar illness who are overweight or obese, the lower histogram compared to the normal weight bipolar indicates that the brain circuits are not as efficient. What's so interesting, this is a first episode of mania. So if you see a patient with a first episode of mania, him or her are obese, their brain is different anatomically and functionally than the bipolar patient, first episode, who's normal weight. And what's so interesting and frankly disquieting is that the degree of reduction in that efficiency we see in the first episode is commensurate with what we see in normal weight bipolars after 5 episodes. Something about obesity is progressing the illness forward at the brain level.